The rationale for PRESEVED-HF trial was very clear. Patients that have heart failure with preserved ejection fraction, well, first of all, heart failure with preserved ejection fraction at this point represents majority of heart failure in the community, and its prevalence is rapidly increasing. Patients that live with heart failure and preserved ejection fraction experience very high burden of debilitating symptoms, physical limitations, and a poor quality of life, and also have significant functional limitations in terms of the ability to exercise and perform physical activities. And in fact, while these patients also at risk of increased risk of mortality and hospitalizations, it's really those symptomatic impairments and functional impairments that are, to most patients with heart failure and preserved ejection fraction, one of their main limiting factors and main concerns that they have to deal with on a daily basis. And so improving those symptoms and physical limitations and the ability to feel better and do more is a very substantial priority, both for patients and clinicians taking care of them. Unfortunately, to this day, they've been, we've come up short in terms of having efficacious therapies that clearly have been shown to improve symptoms and physical limitations and exercise function in this patient population. So it's a huge unmet need. And the purpose of the PRESEVED-HF trial was actually to look at SGLT2, sodium glucose cotransporter 2 inhibitor dapagliflozin, with the idea that using dapagliflozin would potentially improve, address this very important unmet need and improve symptoms and physical limitations and exercise function in this patient population. PRESEVED-HF was a double-blind, randomized, placebo-controlled trial. It was done exclusively in the United States across 26 sites in the United States, and we randomized 324 patients to either dapagliflozin at 10 milligrams a day or matching placebo, and the patients were treated for 12 weeks. The primary endpoint was a Kansas City Cardiomyopathy Questionnaire, which is the health status tool. It's a tool to assess symptoms and physical limitations. And in this particular case, it was a clinical summary score, which specifically focuses on symptoms and physical limitations. And we had a number of secondary endpoints, including exercise function as measured by a 6-minute walk test. What we observed was that patients that were treated with dapagliflozin experienced a significantly greater improvement in symptoms and physical limitations in Kansas City Cardiomyopathy Questionnaire, or KCCQ clinical summary score, of close to 6 points, 5.8 points, which is a very large improvement. It's one of the largest that's ever been seen really with any heart failure medication in any type of heart failure. And it was consistent improvement in both symptoms and physical limitations, both of which were statistically significant. So numerically, in terms of overall numbers, I would say the improvement was large. It was definitely clinically meaningful and highly statistically significant. And it was also consistent across all the different patient characteristics. So there wasn't any subgroup of patients based on where they were from, or their clinical characteristics, or whether they were men or women, whether they were a non-white or white race, whether they had an ejection fraction above or below 60%. All of those subgroups of patients benefited from dapagliflozin as compared with placebo, and so these benefits of dapagliflozin were quite consistent regardless of those characteristics. Also, very importantly, dapagliflozin also significantly improved one of the key secondary endpoints, which was a 6-minute walk test. That's a measure of exercise function. That improved by over 20 meters in patients treated with dapagliflozin as compared with placebo, which again was clinically meaningful and highly statistically significant as well. And finally, dapagliflozin was well tolerated in this patient population, and we did not identify any new safety concerns. So how does dapagliflozin compare with other medications in heart failure and preserved ejection fraction when it comes to those specific endpoints, symptoms, physical limitations, exercise function? As I mentioned before, heart failure been a very difficult condition in which to find efficacious therapies. In fact, it's sometimes called the black hole of cardiology because we've been trying for decades to find efficacious therapies and have not been very successful. Some of the other medications that are used in heart failure with preserved ejection fraction, such as the spironolactone, for example, which is mineralocorticoid receptor antagonist, or sacubitril/valsartan, which is angiotensin receptor blocker and neprilysin inhibitor, based on TOPCAT and PARAGON-HF trial, respectively. The effects on symptoms and physical limitations with those medications in those trials have been much more modest than what we see in PRESEVED-HF. Now, obviously, cross-trial comparisons are very difficult. The patient populations enrolled in different trials are different. And so it's, making these comparisons is always inherently problematic. With that acknowledged, however, as I mentioned before, it's one of the largest improvements that we've seen with any medication in heart failure with preserved ejection fraction when it comes to both Kansas City Cardiomyopathy questionnaires that measures, in this case, the clinical summary score, which is symptoms and physical limitations, and also 6-minute walking distance. There were some previous trials of SGLT2 inhibitors, including both empagliflozin and dapagliflozin, which did not show as large of an improvement before. And I think a natural question to ask, why did we observe such a large improvement in our trial? And I think it has to do, again, with the patient population. We had patients that were much more symptomatically and functionally impaired at baseline in this trial as compared to other trials. And of course, the more symptomatic you are, the more functionally impaired you are, the more likely you are to improve with efficacious treatment. And I think that's the reason why we see such a big improvement here. So the take-home lesson from that is, I think what we see in the PRESEVED-HF trial is that if you have a patient with heart failure and preserved ejection fractions that has a significant burden of symptoms and physical limitations, those patients are likely to benefit from treatment with dapagliflozin. So how do these findings complement other trials of SGLT2 inhibitors in heart failure preserved ejection fraction? So we have a large outcome trial now with empagliflozin in patients with heart failure and preserved ejection fraction called EMPEROR-Preserved that was just recently presented and published. And what the trial demonstrated is that empagliflozin significantly reduced the risk of hospitalizations for heart failure or cardiovascular death. That was mostly driven by reduction hospitalizations for heart failure. So we have a large outcome trial showing that there is a lower risk of hospitalizations for heart failure or cardiovascular death in this population with SGLT2 inhibitors. We now have a trial specifically focused on symptoms, physical limitations, and exercise function showing substantial improvements. And I would remind everyone that in heart failure, including heart failure with preserved ejection fraction, there is what I would say triple goal of treatment, right? There are three main aims or objectives of management. One is to prevent death, make patients live longer. Second is to prevent hospitalizations, try to keep our patients out of the hospital. And the third, as important is to reduce the burden of symptoms and physical limitations and improve quality of life, essentially make our patients, enable our patients to feel better and do more. And so essentially at this point, we clearly have evidence with SGLT2 inhibitors and HFpEF that they address really all of these critical goals of care. So what does that mean? That means that for the first time really in decades, we have a treatment for heart failure with preserved ejection fractions that has, I think, excellent underpinnings in terms of available data now to say that this should be foundational therapy, that should be the first class of medications that clearly has been shown now to address all of the key goals of management. And I think it's going to have important implications for clinical practice and for the guidelines. And of course, we know that SGLT2 inhibitors also do all of these things in people with heart failure and reduced ejection fraction. So we really, for the first time, once again, have a treatment that can be applied and used in patients with heart failure regardless of the ejection fraction and achieve all of those important objectives.